Good afternoon or good morning. My name is Małgorzata Szołkowska. I'm an ITMIC secretary, and it is my pleasure to invite you for our last webinar of series Experts Explain, dedicated to patients with thymic epithelial tumors. And today we have 4 speakers, medical oncologists, Nicolas Girard from the Institut Curie, Paris, France, Arun Rajan from the National Cancer Institute, the National Institute of Health, Bethesda, USA, Heather Wakelee from Stanford University, California, USA, and Tsao from the University of Texas MD Anderson Cancer Center, Houston, USA. And our speakers will talk about clinical trials for thymic epithelial tumors.
Good morning, I'm Nicolas Girard. I'm the head of thoracic oncology at Institut Curie in Paris and the current president of ITMIC. I will discuss 3 clinical studies conducted in France. The first one being RITMIC. RITMIC is not per se a clinical trial. This is a network of centers dedicated to the management of patients with thymic malignancies, with the objective to have an equal quality of care across the French territories. Linked to RITMIC, we have a registry of patients with thymic epithelial tumors in France. The RITMIC network has 15 centers. We have 2 coordinating centers, my center, Institut Curie, and the Gustave Roussy Cancer Center, also in Paris, and we have 13 additional centers to cover the French territories. We have a dedicated multidisciplinary tumor board, which is a national multidisciplinary tumor board to discuss the management of all patients at the time of diagnosis and initial treatment, but also at each step of the management, especially in the setting of recurrences. We are using a web conferencing system similar to Zoom, and this allows each physician to share the patient imaging, clinical reports, pathological reports, surgical reports, and to have a discussion between expert multidisciplinary teams. So this National Expert Tumor Board is held twice a month. We have a systematic pathological review of all the cases with a panel of expert pathologists. We are basing our decision-making on guidelines, which are the ESMO, Clinical Practice Guidelines, linked with the RITMIC guidelines, very similar recommendations. Once a patient is discussed at the National Expert Tumor Board, the patient is registered in our prospective database hosted by the French Intergroup. And at this time, we have more than 4,000 MTB decisions recorded in the database, about 3,000 patients discussed over the past 8 years. So this is a centralized model for the management of patients with thymic tumors. This allows to discuss the management of patients at each step of the treatment and the management. Here is an analysis that we did in 2015 on the first 1,000 patients discussed at the MTB. You can see that questions raised at the MTB are about surgery, primary treatment, diagnosis, follow-up, postoperative radiotherapy, about 1/3 of the questions, and management of recurrences. So RITMIT is a powerful tool to ensure that decisions regarding the management of patients is similar across the French territories. This also allows to be sure of the diagnosis through the pathological review, and this will be useful for the enrollment in clinical trials. So we have a rhythmic clinical trial, which is the phase 3 opened randomized study of postoperative radiotherapy versus surveillance in patients with stage 2B3 Masaoka Koga thymoma after complete surgical resection. Why this trial? First, because as I mentioned, 30% of questions raised at our MTB are about postoperative radiotherapy. And second, because we miss high-level evidence and the algorithm for the decision-making about postoperative radiotherapy is complex. Here is an algorithm from the ESMO clinical practice guidelines. I wrote those guidelines, so I'm partly responsible for this complexity, but this is based on retrospective studies, which obviously may be biased regarding the selection of patients. So we need to have a high-level evidence because postoperative radiotherapy in the mediastinum may be toxic. So we need to make sure that we have a benefit. And this is why we built this very simple trial randomizing patients between postoperative radiotherapy, modern techniques, IMRT, versus no postoperative radiotherapy for thymomas, stage 2B3 Masaoka Koga system, and stratified based on delivery of neoadjuvant chemotherapy. So this is obviously a huge effort. We will enter more than 300 patients. We need to have a long-term follow-up, and the primary endpoint will be disease-free survival. Very complex, obviously, recruitment of patients. So to avoid missing patients, we will go through the rhythmic MTB, and once a patient will be identified as eligible for the trial, the patient will be registered in one of the 15 rhythmic centers. The third trial that I wanted to share with you is Nivotim, this nivolumab versus this nivolumab trial in patients with type B3 thymoma and thymic carcinoma. We have evidence about the efficacy of immune checkpoint inhibitors, immunotherapy, pembrolizumab, nivolumab in patients with thymic carcinomas. And we wanted to build on those phase 2 studies, first to confirm the interest of immune checkpoint inhibitors to ensure access to immune checkpoint inhibitors immunotherapy for European patients in the context of a clinical trial to ensure accurate selection of patients. So this is a Nivotim trial promoted by EORTC and ETOP. This is for type B3 thymomas, thymic carcinoma with 2 cohorts of 60 patients. The first cohort with nivolumab. This cohort is closed. The results will be reported at the next ESMO meeting in Paris in September. And we have a second cohort of 60 patients with a combination of nivolumab plus ipilimumab with a modern dosing of ipilimumab every 6 weeks. The trial is currently ongoing, recruiting patients. So we had a close monitoring of the safety of immunotherapy in this study. And right now, we do not have any signal of toxicity. So this is a very important study, obviously for patients in the setting of refractory disease. Hopefully, we will be able to discuss further the data once the results in the first cohort will be presented. Again, for all those studies, rhythmic, radiorhythmic, Nivotim, team is the key. We need everyone. We need multidisciplinary teams. We need, obviously, patients to increase our knowledge on the management of this disease. We need to have a close communication between physicians, surgeons, radiation oncologists, pathologists, and I think Rhythmic is perfectly illustrate this need. And we need obviously an accurate communication with you patients and share the results of those studies. Thank you.
Hello, everyone. Thank you for your interest in this session on clinical trials for thymic epithelial tumors. And many thanks to Itmic for the kind invitation to participate in this session. I have no disclosures relevant to this talk. So today I will talk briefly about two clinical trials that we are conducting at the US National Institutes of Health for patients with recurrent thymoma or thymic carcinoma. These trials are investigating the immunotherapeutic drugs, avelumab and bintrafusp alfa, which is also known as M7824, in two phase 2 clinical studies. The ID for these two trials is mentioned on this slide, and further details can be accessed from the website clinicaltrials.gov. So the goal of our program is to evaluate various forms of immunotherapy for treatment of recurrent thymic epithelial tumors. At present, our approach is to study immune checkpoint inhibition as a means to activate an anti-tumor immune response. We are also evaluating a novel compound known as an immunocytokine that is designed to modulate the tumor microenvironment and promote an anti-tumor immune response. Of note, checkpoint blockade is the most widely used form of immune therapy in clinical practice, but it represents just one of many potential immunotherapeutic interventions that are designed to harness the power of the immune system. And there is a lot of scope for development of immunotherapy in the future. In terms of potential benefits of this approach as compared to standard cytotoxic chemotherapy or targeted therapy, there is a real documented benefit for a subset of patients, which is durable and long-lasting and eventually translates into an improvement in survival. This is an example of such a case, a patient with a B3 thymoma with right-sided pleural involvement, as shown in the figures on the left. After 18 months of therapy, there was no evidence of disease, and I had presented these data at the last in-person annual meeting of ITMIG in 2019. Almost 2 years later, I'm happy to report that the patient continues to have no evidence of disease, and we have successfully de-intensified treatment to a point where she is receiving immunotherapy once every 3 months. In addition to this durable benefit, most patients who receive immunotherapy, at least with non-thymic cancers, tend to tolerate treatment well with few side effects as compared to standard therapies. This is true also for a subset of patients with thymic epithelial tumors. However, there are potential risks associated with overactivation of the immune system and collateral organ damage. Muscle-related side effects are of particular concern in patients with thymic epithelial tumors, especially thymomas. And the risk profile of immunotherapy for this reason is somewhat different in the thymic population as compared to individuals with other cancers. This diagram on the right shows various side effects associated with immune activation that have been observed in patients with thymoma and thymic carcinoma. As I pointed out, muscle-related side effects, which are highlighted in orange, are increased in incidence as compared to patients with non-thymic cancers, and some of these can be life-threatening. In addition, the side effects noted in purple are the ones that we have observed in our ongoing studies. Most of these side effects are quite uncommon in patients with non-thymic cancers, but even in our situation, if recognized early and treated aggressively, many of these immune-mediated adverse events are well controlled and patients can continue to benefit from treatment. The occurrence of these immune-mediated side effects is one reason why we tend to recommend consideration of immunotherapy for treatment of thymic carcinoma or thymoma in the setting of a clinical trial, so that in the closed confines of a study, these potential side effects can be detected early if they were to occur and be managed aggressively. Moving on to specific details about our two studies, I will start with our phase 2 trial of avelumab for recurrent thymic epithelial tumors. Avelumab is an immune checkpoint inhibitor which targets the receptor PD-L1. It is approved for treatment of Merkel cell carcinoma, bladder cancer, and in combination with axitinib for the treatment of kidney cancer. It is clinically active against recurrent thymoma, and we showed this as part of a phase 1 study of avelumab about 5 to 6 years ago. Building on those early results, we designed this phase 2 trial of avelumab, which started enrolling patients in 2017. The objective of the trial is to determine the response rate to treatment with avelumab. There are several eligibility criteria, but the key ones are listed here, and they include histological confirmation of thymoma or thymic carcinoma, and the disease having been deemed inoperable. Patients should have progression on prior therapy and should also have measurable disease in order for us to determine the response rate to treatment with avelumab. And importantly, patients should have no history of autoimmune disease, with certain exceptions. In addition, we have also included the presence of detectable acetylcholine receptor binding antibodies as an exclusion criterion, after we noted that patients with muscle inflammation as a complication had, without exception, detectable antibodies prior to start of treatment. Here is the study design. Avelumab is administered at a dose of 10 milligrams per kg in eligible patients at 2-week intervals, and treatment is continued until disease progression or development of intolerable toxicity. CT scans are performed every 6 weeks to determine response. Of note, in patients who are responding to treatment or have disease stabilization after 12 months of treatment, we de-intensify dosing so that patients are treated once every 4 weeks for a period of 6 months, and then at 3-month intervals if they have an ongoing response. We collect blood for immune analysis at specific intervals, and we also offer pre- and post-treatment biopsies for patients who are interested, so that we can interrogate the immune activation in the tumor more precisely. These are some preliminary results from the trial after enrollment of 23 patients. I had presented these data at an immunotherapy conference in 2019. As you shall see, a large proportion of patients received treatment for prolonged periods of time, extending beyond 1 year. And we have a significant fraction who are receiving treatment several years after they enrolled on the clinical trial. Adverse events have been seen across histologies and are fairly manageable and certainly not very common. We also see that clinical benefit is seen across the spectrum of thymic histologies, and can range from disease stabilization to an objective response. 30 patients have been enrolled to date, and we have 9 open slots for thymoma and 12 open slots for patients with thymic carcinoma. The study contact for this trial is our research nurse, Ms. Shannon Swift, and the contact information is included on this slide. Moving on to the bintrafusp alpha trial, this is also a phase 2 study for recurrent thymoma and thymic carcinoma. And like the avelumab study, it is a single-arm study with no placebo group. In other words, all patients receive active treatment. I will also point out at this stage that both the avelumab and bintrafusp alpha studies being conducted at the NIH are perhaps the only ones which allow for enrollment of patients with any histology of thymoma, as also for patients with thymic carcinoma. Now, bintrafusp alpha is a novel immunocytokine which has 2 targets, PD-L1, like in the case of avelumab, but also transforming growth factor beta, or TGF-beta, which is a cytokine which has immunosuppressive effects. Bintrafusp is under investigation in several trials for various indications. We decided to design a study for thymic epithelial tumors after noting that high levels of TGF-beta were observed in with these tumors, especially thymic carcinoma. And it has also been reported that it can affect survival adversely. So this is just a graph showing those elevated numbers in samples derived from patients participating in our avelumab study. And this overexpression is particularly noted in individuals with thymic carcinoma. So as with the avelumab study, the bintrafusp trial is designed to assess the objective response rate. The eligibility criteria are similar in that there should be inoperable histologically confirmed thymoma or thymic carcinoma. Patients should have progressed after prior therapy and have measurable disease. And they should not have a history of autoimmune disease, again, with certain exceptions. And they should also not have detectable acetylcholine receptor binding antibodies. The study design is fairly straightforward. Bintrafusp is administered at 2-week intervals until disease progression or development of intolerable toxicities. Unlike avelumab, we use bintrafusp at a flat dose of 1,200 milligrams intravenously, administered over 60 minutes. Now, this is the standard dose that is used in other clinical trials for non-thymic cancers, and it is a clinically active dose. We perform various correlative studies using blood and tissue when available, and restaging is performed generally with CT scans, which are performed at 6-week intervals. Now, there is not much to say about results because this study has opened recently and only 2 patients have enrolled. Both are doing well so far. There are 6 to 16 open slots for thymoma and thymic carcinoma each, and the eventual number would depend on the number of responses that are seen in the first 7 patients. Once again, the study contact for this trial is Ms. Shannon Swift, and her contact information is included here. So with that, I would like to conclude. Thank you for your attention, and I'm happy to take questions at the end of this session. Thank you.
I'm Heather Wakelee from Stanford University in California, and I wanted to speak with all of you about an ongoing trial. It's a phase 1/2 trial looking at a combination of 2 drugs. One is nivolumab, also known as Opdivo, and the other one is vorolanib. And this is for patients with thymic carcinoma. For those of you who want to read about a lot more detail on clinicaltrials.gov, this is NCT 035838086. You have that in your information as well, though. And what I wanted to do was, instead of showing a lot of slides, talk with you about what we're hoping to find with this trial and look at. And so I wanted to talk to you more about the 2 drugs that are included. So nivolumab is one of our immune checkpoint inhibitors, PD-1 drugs. And those have shown activity in multiple different solid tumors, including patients with thymic carcinoma. And when we talk about thymic malignancies, of course, there's thymoma and there's thymic carcinoma. And it's important to remember that the thymus gland is really critical to the immune processing of the body. It's where the immune cells, the T cells, are taught what's normal tissue and what is not normal tissue. And so it's really critical to the regulation of autoimmunity, meaning diseases that attack where the immune cells attack our cells. And also really important for helping to make sure that immune cells recognize foreign things such as tumors or infections. And it's for that reason that when we talk about thymomas, we see a lot of autoimmune diseases like myasthenia gravis and others. With thymic carcinoma, that doesn't tend to happen very often, but it can. And so in the trials that looked at these immune checkpoint inhibitor drugs alone, like pembrolizumab or nivolumab, what was seen was that those drugs could work maybe in 20-30% of people with thymic carcinoma. But in that group, even, they did bring in some autoimmune diseases. And in patients with thymoma, the risk of autoimmune disease is incredibly high, and we don't think that's safe. So that's why this trial is only for patients with the thymic carcinoma and not the thymoma. and it's using this nivolumab PD-1 IV infusion drug that's given every 2 weeks. Now, the other drug, vorolanib, is a pill drug. It's not approved. It's in the class of drugs that are anti-angiogenesis agents, ones that block this VEGF pathway. Some of you have heard of that. So VEGF drugs are things like bevacizumab, ramucirumab, which you'll be hearing as part of another trial, and then the sunitinib, and other drugs like that, which have shown activity in thymic carcinoma as well as thymoma, but a bit more in the thymic carcinoma. So when we think about the sunitinib drug, there was activity particularly seen in the thymic carcinoma patients, and that's an approved agent that we have, but unfortunately it has some toxicity. And then there have been some other drugs that are also used that are these VEGF targeted pill drugs, which also have shown some exciting activity and are available agents. But what this trial is trying to do is take both of those approaches and put them together. So taking the VEGF targeted agent, vorolanib, and the immune therapy drug with the nivolumab and putting them together. And the vorolanib, its advantage over some of these other VEGFR pill drugs is that it is a small molecule that is better tolerated. So it was designed to be better tolerated. It doesn't cause as much of the high blood pressure. It doesn't cause as much of the overwhelming fatigue that can sometimes be seen. And so we thought that would be a good combination to pair together. And so that was the reason, the rationale for designing this trial. The combination is also being looked at in some lung cancer patients as well, but I wanted to specifically focus on the thymic carcinoma patient population, and that's why this was included. The study is open at Stanford, it is open at Vanderbilt, it's open at several other centers around the country, and that's where that clinicaltrials.gov site would be helpful. It is open for patients with thymic carcinoma that is not amenable to surgery or other curative options for patients where the disease has spread. It is open to patients who have had any number of prior treatments, as long as those prior treatments do not include drugs like sunitinib and others that have been, like lenvatinib is another one of that class, that are very similar to vorolanib. So patients could not have had that, but they can have had the ramucirumab, the IV drug, or the bevacizumab, the IV drug. They also cannot have previously had any of the immune checkpoint inhibitors. So they cannot have had pembrolizumab, they cannot have had nivolumab or any of the other immune PD-1, PD-L1 drugs. So that's kind of the main exclusion to be aware of, but otherwise thymic carcinoma, any number of prior lines of treatment, as long as it's not one of those two classes. And then most of the other exclusion criteria have to do with safety. So making sure that someone would not be at significant risk of either having an immune therapy drug, as in no evidence of underlying autoimmune disease already, and not at risk from these VEGF agents, so hypertension that's controlled, things of that nature, and that the person's overall in reasonably good shape. And we haven't had a lot of patients go on yet, so it's hard to really get a sense of how well it's working, but I was very encouraged this week in seeing one of my patients who recently started, who came in saying he was feeling fantastic. Now, that doesn't mean everybody who goes on the treatment is going to have that good of a response to it, but we are hopeful. We have seen some patients develop the autoimmune problems. That again is a risk with any of these immune checkpoint inhibitors. The good news in that situation, not that it's ever good news to have that kind of a toxicity, is that we were able to stop the nivolumab in those rare cases, and either because there was ongoing immune response or because the vorolanib itself was still helping the pill, the VEGF pill, those patients were able to continue to stay on with their disease controlled, at least couple that I've been taking care of. So that's the drug combination trial with nivolumab and vorolanib. It's early phase, meaning phase 1 and 2. There's no randomization. Patients who are enrolled will definitely be getting the treatments. And again, it's limited to thymic carcinoma patients because of the toxicity risk. The idea behind it was to combine both the VEGF and the immune therapy together. And it is open, and so if you or anyone you know might be potentially interested, please reach out to us. Thank you.
Hi, I'm Dr. Ann Tsao at the University of Texas MD Anderson Cancer Center, where I am the current thoracic section chief as well as the center medical director for the Thoracic and Orthopedic Center. I'd like to thank all of you for taking the time today to listen about the next two studies, the SWOG 1701 trial for frontline patients with thymic carcinoma, and also the pembrolizumab study for thymoma and thymic carcinoma patients. The first of the trials I will review is S1701, a phase 2 trial of carbopaclitaxel with and without ramucirumab in patients with locally advanced recurrent or metastatic thymic carcinoma. This is sponsored by the Southwest Oncology Group through the NCTN network. Thymic carcinoma, as you know, is a rare malignancy that arises from the thymus, a WHO type C. We have few treatment options that are dedicated to this disease at this time. So obviously there's a significant drive to try to find improved therapies for our patients. We know that there are several case reports and phase 1 subgroup analyses with the anti-angiogenic agents that have demonstrated benefit for our thymic carcinoma patients. There are different biomarkers that look to be overexpressed, some of which are focused on the angiogenic pathway, such as vascular endothelial growth factor ligand and receptor. Now, we know that there's high expression of both in thymic carcinomas, and we also have this drug, ramucirumab, which is a monoclonal antibody that targets VEGFR2, and it already has regulatory approval by the FDA in several other tumor types. So the thought was to combine the ramucirumab with chemotherapy in the frontline setting for our patients with thymic carcinoma, and to see if this would have better survival outcomes. This is the trial schema. Again, patients have to have no prior therapy, and they would receive carboplatin paclitaxel for up to 4 to 6 cycles of treatment with or without the ramucirumab. In the patients who are randomized to the ramucirumab arm, they would continue on maintenance therapy, and that would be given once every 3 weeks. And during that time, CT scans or PET CTs would be done every 9 weeks to monitor progress. The primary endpoint is progression-free survival, and secondary endpoints are safety, toxicity, response, duration of response, and survival. Our target enrollment is 60 patients, and we do have an interim analysis for efficacy designed into the trial. There are several inclusion-exclusion criteria, essentially no major surgery within 4 weeks prior to initiating the protocol, and certainly, unfortunately, because we are dealing with an anti-angiogenic, any patients that have bleeding disorders or clotting problems would unfortunately not be eligible for this trial. The remainder of the inclusion-exclusion criteria are pretty standard. The second study that I'd like to comment on is a pembrolizumab, or otherwise known as the trade name Keytruda, trial in patients with thymoma and thymic carcinoma that is unresectable. And this is a feasibility study being offered at MD Anderson Cancer Center, and it is being supported by Merck. So the reason for this trial is we know that the thymus is an immune organ that regulates T cell selection and has activity with immune homeostasis and self-tolerance. So it would be reasonable to hypothesize that our patients with the thymic malignancies would potentially benefit from these immune checkpoint inhibitors. So we proposed this initial feasibility trial, knowing also that there have been other studies suggesting that the immunotherapies can be dangerous with autoimmune disorders that can occur in our patients with thymoma. In thymic carcinoma, there's less of a risk of any autoimmune disorders, so we are not as concerned with thymic carcinomas. But nevertheless, with thymomas, we have to be careful. So this trial was designed to have a safety run-in. So we actually have already completed the safety run-in, and luckily we met the criteria for safety. Now we are being very stringent in who we are allowing onto the trial. No one can have an autoimmune disorder or anything that may potentially be an autoimmune disorder. So the patients will receive pembrolizumab, 200 milligrams IV every 3 weeks for up to 35 treatments. And once they complete treatment, after they're off therapy, they may potentially have the option, if they choose, to also receive the pembrolizumab later on, should their disease begin to grow again. Now, we've already completed the part 1 portion of this trial. We are currently in the part 2 expansion phase, where we are looking for 24 total patients. And again, no history of any autoimmune disorder can be allowed. Patients will receive the pembrolizumab, 200 milligrams IV Q3 weeks, again for up to 35 treatments. And once they complete therapy of 35 treatments, they are monitored essentially every 3 months. And then if they do develop any progression of disease, they can be rechallenged with the pembrolizumab for up to a year. Now, we are going to be looking at safety tolerability. We are ensuring that hopefully none of our patients will have development of any grade 4 or 5 autoimmune disorders. And then our secondary objectives will be clinical outcomes of response rate, progression-free overall survival, and duration of response. We do have translational objectives built into this with the PD-L1 immunohistochemistry, and then also plasma profiling. And so these are currently where we are at for those 2 studies. I did want to make one more note about the eligibility. As I mentioned, we're very stringent for the pembrolizumab trial. And so you can see a list of the eligibility criteria here, but also there's quite a lengthy list for exclusion. Now, in general, if you do not have an autoimmune disorder, we are happy to get you considered for this study. If you do have pembrolizumab, if you do have a thymoma or thymic carcinoma and are interested in the pembrolizumab. Thank you so much for your time.
Thank you very much, all the speakers. First, short information for our audience. I guess that you are interested in contact details, how to reach these trials, these researchers. Don't worry, all contact details will be published on our webpage, so you don't need to worry about it and to write the information now. First, before we start with questions from our audience, I can see that we have some. I would have a question to our speakers, to all our speakers. Do you do you recruit also patients with thymic neuroendocrine tumors in your studies or not?
So I guess I could go first. This is Arun. So for our studies, the answer is yes. They are potentially eligible if they meet other criteria. Thanks.
Mm-hmm. Thank you. Nicolas? Or... No, Nicolas. And I see that you wanted to answer.
Yes, so for the S1701, if it is a predominantly thymic carcinoma, then yes, we can enroll them. For the pembrolizumab study, we are accepting it as well, provided no autoimmune history of disease.
Same in Nivo team, we are also taking the B3s as well as the thymic carcinomas. And in the first part of the trial, which is now completed and will be presented at ESMO meeting, we do not have any signal of increased toxicity. Again, check for all the immune and the autoimmune disorders is mandatory with an extensive, especially biological check for all those autoimmune disorders before enrolling the patients.
Yeah, but I was asking about thymic neuroendocrine tumors. Do you recruit patients with this kind of histology? Neuroendocrine tumors, carcinoids and so on?
Not carcinoids, but neuroendocrine carcinomas may be eligible.
Okay. Heather, I'm not sure if you are with us.
Yeah,
not yet.
I'm here.
Oh yes, nice to see you.
Yeah. So the vorolanib, vorolanib study is not particularly open to the thymic neuroendocrine. It was more focused on the true thymic carcinomas. I don't have the eligibility right in front of me. I don't know that we specifically excluded, but the mechanism of how it would work, it's not clear that would be the best choice. But if there's a specific patient who's interested, we can look at it. It's a relatively smaller study. I don't have all the eligibility right in front of me. So we definitely excluded the thymomas because of that risk of neuroendocrine, of autoimmunity, like I mentioned before. So.
Okay, thank you. Okay, so let's start with our questions in chat. First question from Ritsuko. Shall we treat thymic carcinoma like non-small cell lung carcinoma? Question to all.
I think that this is a very distinct entity from non-small cell lung cancer. We tend to see a very different patient population, demographics, side effect profiles. So I don't think that we can extrapolate from non-small cell lung cancer. Now, with that said, I do think that some of the treatments that are being administered with our non-small cell lung cancer patients hopefully can be utilized in thymic carcinoma. But again, remember, the non-small cell lung cancers tend to be, for the heavy smokers, tend to have a large number of genetic alterations, and thymomas and thymic carcinomas tend to not have that. And they are considered, what we call colder tumors. And so there's a different biology, a different natural history, and we have to treat these patients as such.
Mm-hmm. Any other
Yeah,
comments?
I would agree that many of the treatments, if you just step back, there are parallels because a lot of the treatments are chemotherapy, which work across a lot of different malignancies, but they are definitely different diseases. And so that's why we have all these exciting trials, is trying to better understand what's the best treatment. Many of the drugs are similar, but there definitely are distinct differences in how they behave. So I think it is important that we have groups like this where people are focused on knowing about these rare diseases and some of the best treatment options for them.
I agree. I think there are two different diseases essentially. I think extrapolating from lung cancer to some degree, we are forced to do it under certain circumstances with chemotherapy, etc. And there are drugs which work for both histologies, but there are huge differences. It's not the same disease. Things like maintenance therapy, which is commonly used for stage 4 lung cancer, I've seen it sometimes extrapolated to thymic carcinoma, and I'm not sure there is data to do so. And regarding immunotherapy, of course, there are huge differences, as Anne and Heather have pointed out. I think it's very, very important to recognize that thymic carcinomas, patients with thymic carcinoma are also prone to these autoimmune side effects, which can sometimes be very serious. So I think to completely extrapolate what's done in lung cancer to thymic cancers, including thymic carcinoma, can sometimes be a little risky. And I agree, these are two different diseases which need two different paradigms of management.
Okay, next question. Is it possible to get another checkpoint inhibitor like avelumab or nivolumab if pembrolizumab has already been tried and that had no effect?
That's a very good question. Actually, if we do not have a response to any anti-PD-1, PD-L1 treatment, the chance to get a response with another one will be very low. Even in other solid cancers where we have more data, more trials, it is even unclear whether it's valuable to do that and whether it may provide some benefits. So I would be actually cautious with such approach, and personally I do not propose that to my patients.
Yes, Arun?
Yeah, I completely agree with Nicolas. I think if monotherapy with an immune checkpoint inhibitor hasn't worked or hasn't been effective, then it's unlikely that another immune checkpoint inhibitor targeting the same molecule, the same pathway, would likely not be effective. There are some data to suggest that if a PD-1 inhibitor has been used previously and you use a PD-L1 inhibitor later, that there may be some activity. But I think that's it's relatively scant data. So I completely agree. I think if one hasn't worked, then I would probably look at something more novel, some sort of combination or some other treatment approach altogether. And for our studies, just for the record, if you have received, just like with the other studies discussed today, if you have received either pembrolizumab or nivolumab previously, then you're not eligible for this reason. Thank you.
I will add, and following up on one of the questions in the chat, which it's just that if someone's had immune therapy, sometimes their response to chemotherapy seems to be somewhat primed and a little bit better than expected. That's a phenomenon that's been seen. Sometimes I don't know that we really understand it or can fully explain it, but it is possible that if you see no response to immune therapy and then you go with a different strategy like chemo, sometimes that response is better than might have been seen without it. And I do think that we have an opportunity to continue to explore if immune therapy alone doesn't work. And as been explained, the thymic carcinomas don't tend to respond as well as some other solid tumors because they do not have as many mutations as some other types of cancers. So that's perhaps why combinations with immune therapy might be better. As Arun just said, our trials tend to say if you've already had immune therapy, you can't have it again as part of a study because we don't know how that's going to impact things. But you know, these are things that'll be important to ask. And again, this is different than lung cancer, but all of us on this call tend to treat lung cancer also. Definitely had patients where on immune therapy not working or stops working, add chemotherapy to it, suddenly they're responding again, and more so than I might have expected with the chemo. So I think it's something that's worth exploring, but none of the studies we talked about today are specifically asking that question.
Okay, thank you. And now there is another question. Why are historically most clinical trials just combining established therapies in new combinations? Is there no money available to do new research, or is it a function of pharmaceutical companies funding these trials and looking for new sources of revenue for the products? Who would like to answer this question?
I'll jump in there. It's a little bit of a loaded question, but I think that when a new drug is being developed, you obviously want to, the pharmaceutical companies are looking to see where is it going to work best, who is it going to help the most, but they're also then looking at market, of course. So if you have two diseases and one's very common and one is not common, they're going to be thinking about the more common disease first. But then when a treatment has been shown to work in a more common disease, they're more open when we approach them to say, hey, we'd like to look at it in a less common disease like a thymic malignancy. There certainly is work being done in trying to understand thymic malignancies directly, you know, a huge effort at understanding the molecular changes and seeing if there might be a novel target that hasn't been as successful as we were hoping. And obviously, you know, some of the work that Arun is doing is really based on investigator work also. And many of the trials we've done have been investigator initiated, where we as investigators said, hey, we want to look at this drug that's already being studied for other diseases in thymic carcinomas, because not all of the companies do think about these diseases as much. So it's sort of a back and forth. I wouldn't necessarily paint the pharmaceutical companies as evil in that way. I think it's just that, you know, they're looking at how can they take whatever they've developed and use it for the most people to help them. And we're obviously looking at it from, if there's a way that we can specifically target, we'd like to do that. It's just been very hard to figure that out. And if we had an idea and went to a company that had a compound and said, we think it's going to specifically work in thymic malignancies for this reason, I don't think that would be a problem. The funding's a whole other question, but maybe you all other folks who were being quiet there want to take a stab at this.
Yeah, I think I agree. You know, our trials here definitely are all investigator initiated, and you know, we make an effort to let the science drive the trial. I think a few points to keep in mind, as Heather mentioned, you know, these are different diseases altogether. So even if a combination or a certain drug has been evaluated in another indication, I think there's still a lot to learn and incremental, you know, gains by exploring it in this particular for this particular indication. The other thing to point, which I would like to point out is, there may have been different teams in different countries that started, initiated trials with a certain drug at around the same time. And, different trials may accrue at a different pace. So ultimately, you may notice that there are many trials going on investigating the same drug. But I think all those teams that are putting effort into this are coming from different directions. I think the correlative science, which is included for each of these trials may be different. So it's not exactly replicating the same thing, in another study. So I think there are subtle differences between these studies, and just the pace of evolution of these trials may so dictate the fact that there are overlapping studies. But I think each of these trials helps us learn and move the science forward. And especially, if these are investigator-initiated trials, and all of us on this call, we make an effort to let the science drive the study forward and develop the drug further. So I think there is something to learn from each of these trials.
Mm-hmm. Thank you, Arun. There is a continuation of this question. Has there ever been any trial looking at cryoablation versus radiation or chemo with thymic tumors? Have you ever tried such a method, cryoablation for thymic tumors?
At the NIH, we have, not as part of a clinical trial, but we have used thermal ablation and including cryoablation, microwave ablation, etc., in patients who have thymic epithelial tumors and have received other treatments and have limited amount of progression. So, for example, if there are 1 or 2 lesions which are progressing and are amenable to these local ablative techniques, we have actually used it. On a case-by-case basis, if we were to analyze those individuals, I think there has been some benefit, but it's very difficult to comment objectively because it was not done as part of a clinical trial, and we just don't have those data. So I don't want to overstate, what these methods might have added clinically. The short answer, if the question is it being done as part of a clinical trial? We certainly don't have any studies at the moment for thymic epithelial tumors exploring those combinatorial approaches. And I'm not sure if there are others elsewhere.
Mm-hmm. Okay. And next question. Yes?
Oh,
yes?
Can I just add to? I think with cryoablation in general, there aren't that many trials in any diseases. I mean, that we know it's an effective strategy, and I think it would be something where if there was part of it has to do with the locations too of these tumors. Cryoablation is used more often when there's a disease that's in the liver or in some other place where with the treatment, the margin around it is not as critical because it's not as precise as some of the very, the specific radiation, right? You can really sculpt radiation into shapes that are not round, but are shaped to the size of a tumor. With cryoablation, you get a very round treatment of area. And so if you have a round treatment of area in the liver, that's relatively safe. If you have a round treatment near the mediastinum, that might be not safe. And I think that's probably why we haven't used it as much, and why one of the techniques that is looked at, more so in thymic malignancies than some other, are the proton therapies, that version of radiation, because that's on the other side where it's even more precise sculpting. And when you're right near the heart and major vessels, that's even more critical. We don't have a proton therapy center. I'm not trying to plug that. It's sort of, when you think about what's the advantage of cryoablation, you're not using radiation, but you don't have the same precision in what you're sculpting. And so that's maybe one of the reasons we probably won't be studying it as much in the thymic malignancies. So.
Thank you. Next question. Is there experience with very late response after immunotherapy with pembrolizumab? My father had growth during the therapy. A few months later, after another chemotherapy with paclitaxel, there was a decrease and he had stability for a year. Could this theoretically still be attributed to the immunotherapy?
Right. So I was trying to get at that before. Go ahead, Nicolas. Sorry.
No, go ahead. No, that's a really good news. And the point with immunotherapy is the possibility for such late responses and sustained responses. So sometimes some time before being effective. And here we have also possibly an interaction between immunotherapy and chemotherapy. And we discuss a lot about immunotherapy as single agent to replace chemotherapy, but maybe similar to what we are doing, for example, in lung cancer, we may combine immunotherapy plus chemotherapy in some patients. And maybe this is the next generation of clinical trials.
So I'll add theoretically, it's definitely a possibility. I think in practice, we have all seen that as well, to Heather's point about, chemotherapy working after immunotherapy. I too have the sense that some of my patients who have come off our trials and gone on to receive single agent, pemetrexed or other forms of chemotherapy, have received it for long periods of time, maybe longer than they would have otherwise, but there's a bit of speculation in that because there is no control. But there's certainly a pattern where they've received it for long periods of time. And to the point that Nicolas just made, even with immunotherapy alone, there can be delayed responses, and we have seen it. We have actually, I'm sure all of us have seen situations with immunotherapy where initially the disease seems to worsen, especially if you do something like a PET scan, you see more activity, probably because of inflammation, etc. And I've seen multiple instances where you just give it enough time. If a patient is doing well clinically, you continue treatment, and eventually everything settles down and you begin to see a response. So this is the concept of what's known as pseudo progression. Many a times we tend to overestimate it. The numbers are still small, not to say that everyone would have this pattern of response, but there is clearly a small fraction where this is real, it happens. So in the example provided, there certainly could have been a delayed response to either pembrolizumab itself, or the fact that chemotherapy was added on, and these tumors may be slightly more chemosensitive after prior exposure to immunotherapy.
Thank you. Heather, would you like to add something?
I know I was trying to get at that. I saw it before, so I was trying to get at it with the other earlier discussion, just that idea that we do sometimes see responses from immune therapy where we see the chemotherapy tending to work better, but it's just hard to prove it, but we've definitely observed that.
I wonder, because a lot of studies are dedicated to immunotherapy, I wonder whether the expression of PD-L1 is assessed before recruitment of the patients of course, in thymic tissue, tumor tissue, actually.
So in the studies that we are conducting at the NIH, the answer is no. We do not use PD-L1 expression as an inclusion criterion, but we certainly assess it to look for correlations later on. In our experience, at least certainly for thymomas, PD-L1 expression doesn't seem to correlate very well with eventual development of a response. And I think it speaks to the fact that there are other markers of response that we don't fully understand. These are very unique tumors, as we have all pointed out. They're intimately related to the immune system, and there are certainly other possible biomarkers that have not been uncovered. So the answer is no. We don't like to exclude patients based on PD-L1 expression, because it may, you may be at risk in excluding patients who may otherwise benefit.
I think there's some correlation, right, with the PD-L1 expression and probability of response in the study so far, but our study doesn't exclude it either, and I think we're still trying to understand that. I agree with you, and there probably are other biomarkers too.
And PD-L1 expression is actually a hallmark of thymic cells, even in the non-tumoral thymus. So very difficult to know if the PD-L1 that we are looking at is related to immune response or is just part of the normal function of thymic cells.
Yeah, so we don't use PD-L1 as an exclusion for any of our trials either, for thymoma, thymic carcinoma, for exactly the reasons outlined above. And I would also just make the point that in some of the colder tumors like mesothelioma, we have seen trends in correlation of PD-L1 expression to response to immunotherapy, but it is by no means a good biomarker that's predictive. And I think that we may see that as well in the thymic epithelial tumors as well.
And I think one other point I'd just like to make is, all of us are moving on to a phase where we are trying to explore combinatorial approaches, combination immunotherapy. And one of the aims of these sort of novel combinations is to decrease your reliance on one particular marker, such as PD-L1, So if you have a combination, for example, with an anti-angiogenic or a DNA repair inhibitor or, an immunocytokine like the one we are using, our hope is that we can work our way around just one factor, such as PD-L1. So even if it does have a role, you're not so much dependent on it. And that is also one of the reasons we are not, dependent on it and don't check it as part of eligibility.
Okay. So thank you very much. Thank you all the speakers that you found some time to join this webinar to prepare your talk to explain us about your trials. Thank you all participants for your questions, for your attendance. It was the last hour webinar of Series Experts Explain, dedicated to patients with thymic epithelial tumors. But perhaps not the last webinar for patients at all. So please visit our webpage. We will inform you about our future plans. At this moment, I can tell you that in the second half of a year, we are going to organize our ITMIC annual meeting. You can read all details on our webpage. Of course, patients can join this meeting. However, the truth is that the sessions are dedicated rather to physicians, so maybe the topics discussed may occur too difficult for patients. However, everyone is welcome. So thank you again. Thank you for the series. Thank you, speakers, participants, and have a good the rest of the day. Thank you very much. Bye.
Thank you.
Thank you. Bye-bye.
Bye.